You're listening to Medscape's In Discussion series on esophageal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Samuel J. Klempner. Dr. Klempner is an associate professor and director of gastroesophageal medical oncology at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. Relevant disclosures can be found with episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston, and welcome back to this Medscape In Discussion Esophageal Cancer podcast series. Today we're going to discuss targets and approaches in early development for esophagogastric cancers, as well as cover some recent data from ASCO. First, let me introduce my guest, Dr. Haeseong Park, who's a friend and colleague across town. Dr. Park is an associate professor in the Division of GI Oncology at Harvard Medical School and Dana-Farber Cancer Institute here in Boston. So welcome, Dr. Park, to In Discussion.
Hi, thank you so much for having me.
Let's jump into this. Maybe we'll start with a similar question we've been asking a few others who've been on the podcast series, which is how they're going to adopt this ESOPEC data into, real-world clinical practice. So let's say you've got a patient that comes in next week with a distal esophageal adenocarcinoma. You do your staging workup, and it's clinical T3N1. Tell us a little bit sort of the broad available approaches and then what ESOPEC was kind of asking.
Now that the ESOPEC data is out, I think we'll be recommending FLOT over the cross-chemoradiation regimen. So ESOPEC was asking which approach had better long-term survival, FLOT perioperative chemotherapy in this population versus the cross-carboplatin paclitaxel concurrent chemoradiation in the neoadjuvant setting. In our practice, we have concerns about tolerability with FLOT, so we will probably be selecting patients based on that. If they have good performance status, if they look like they can tolerate FLOT regimen, we'll probably recommend FLOT over the chemoradiation approach. I think a few things that have already become a topic of discussion at our institution is for patients who have a high PD-L1 CPS score, do we incorporate immunotherapy? Would it make more sense to use cross so that they can have access to adjuvant nivolumab versus trying the peri-op FLOT without immunotherapy? Those have been some points of conversation. So I think there are some caveats to the ESOPEC trial, but overall, I think we'll prefer FLOT over the cross regimen from now on.
Yeah, I completely agree. I think it's a systemic or at least a high risk of systemic failure disease. Pushing on the systemic disease control is probably going to be the path to getting us to improved outcomes. Just very, very practically speaking for our listeners, we all sort of have this gut sense of like someone comes in the door, are they a FLOT candidate or not? What do you look for or how do you assess that question?
That is a great question. In my practice, I look at whether the patient walks in or not. That's the first thing that I look at. How much weight they have lost from their disease and any other comorbidities. Are they healthy enough to tolerate triplet chemo regimen is what we typically look at.
Yeah, I think those are probably the main ones. I personally wind up doing relatively frequent dose reductions and tweaks that we've all gotten used to over the course of giving FLOT for true gastric cancers. And I think it's just going to be a learning curve probably for everyone to expand the FLOT into the true esophagus, but basically look for very similar things. And honestly, sometimes we do wind up backing off from FLOT to full FOX or consider dose reductions. I'm assuming you kind of do the same.
Yep, absolutely. I think we've come a long way, though, since the FLOT data first came out several years ago. Back in the day, I think our approach was more using full FOX as opposed to like trying the triplet regimen. But I think we've become a little bit more accustomed to managing the side effects from the FLOT and maybe a little bit more comfortable using the triplet regimen in this setting.
Totally agree. I know, it's intensive for everybody, but bringing people in for tox checks and hydration and all these kind of things, I feel like we're all just getting better at it. Let's take this same case. Let's say you gave them FLOT per the ESOPEC data, and then they have an R0 resection, they finish out their FLOT, and then a year and a half goes by, and they come back with a liver met and some retroperitoneal nodes. Tell me a little bit about your approach to PD-L1 testing in guiding frontline decisions.
Yeah, and this is another area that I think we've learned fairly quickly since the data came out. We test PD-L1 in nearly everybody, regardless of their stage, knowing that even the patients with locally advanced data, like half the time their disease comes back, even with the best treatment, such as FLOT. So we try to get that as soon as possible. We do it internally. Our turnaround time for PD-L1 CPS is relatively quick. And I've been noticing even patients who get diagnosed at outside institution in the community setting, their turnaround time has become a little bit shorter than before. I think we have the best data on negative benefit in patients with completely negative PD-L1 expression. But as far as how positive it has to be and where the CPS cutoff should be, I think that's a little bit more difficult to tease out. Several studies have used different assays, different cutoffs. So in my practice, it's almost become a binary at this point. So is that negative or any positive?
Yeah, I think that's kind of the way the field seems to be moving. You know, we've got Keynote 859 that's got a greater than 1 pre-specified. We've got 649 with greater than 5 in everybody. And I think it does seem that we're coalescing around limited, if any, benefit for the less than 1. And then everybody else probably will be considered for checkpoint inhibition. I know that your own work is trying to build somewhat on these standards. And in Germany, people get FLOT as a frontline regimen, you know, with checkpoint or with trastuzumab. But tell us a little bit about what your frontline trial is seeking to answer.
Yeah, my trial is try to establish FOLFIRINOX as a new triplet regimen that's potentially better than FOLFOX and or FLOT in this situation. I think prior trials looking at the triplets using the taxane showed maybe marginally better efficacy, but it tended to be way more toxic. And also these prior trials with the taxane triplets, they were developed many, many years ago where there were no real good third-line treatment options. And a lot of patients did not receive second-line therapy at that time. So our thought process was starting with upfront triplet with a more effective and possibly less toxic regimen, such as FOLFIRINOX, as opposed to FLOT or DCF. Maybe that's a better approach. Maybe patients can get exposure to these additional agents early on and possibly lead to better outcomes. And even with the advances in targeted therapy and immunotherapy, these combination chemotherapy backbone is still necessary for treatment of gastric and esophageal cancer. So we're looking for that better chemotherapy backbone.
Yeah, I think you raised some really important points. Even in big centers like yours and mine, and even in phase 3 trials, it's kind of humbling to see that only, 40 to 50, 60% of patients even make it on to subsequent therapies after frontline therapy. And in centers that are participating in these phase 3 trials, which are good places, it's a reminder that there's a good rationale to push on frontline therapy. And it's kind of funny, you know, we all have come along with FOLFIRINOX in terms of feeling quite comfortable with managing FOLFIRINOX, and FLOT has this perception of being more toxic, but I'm not sure that I'm aware of really like FLOT versus FOLFIRINOX data. I'd have to maybe compare those AE tables side by side someday. And then your study does allow for people to get biologics on top per standard. Is that true?
Yep, that is correct. So when we developed the trial, the only addition that was considered standard was PD-1 inhibitors. So as of now, we're allowing patients to get PD-1 inhibitors if it is indicated. So for those with CPS 5 or greater, they're actually mandated to receive PD-1 inhibitor on top of it, as long as they don't have any contraindications. And those with less than 5, it's optional.
Yeah, I think it's a very pragmatic study. And I remember, probably you remember too, when we were starting out, like I actually used to give DCF, not that infrequently. It is an active combination, but it's not so easy. And Now we've swapped out the cisplatin for oxaliplatin. Let's say this patient who has recurrent disease goes on your study, gets FOLFIRINOX plus nivolumab, does well for a year, and then begins to progress. What are sort of the targets or approaches that you're interested in second line and beyond? And maybe just start by saying, like, what would be your standard second line approach in someone who progressed on FOLFIRINOX and nivolumab on your study?
So that's where it gets interesting. So I guess the patient was started on FOLFIRINOX since they had HER2 negative disease. And the standard option that we have is ramucirumab paclitaxel still. But I think we have several novel biomarkers. We know the Claudin 18.2 and FGFR2b have some activity in the first line setting already. And there are also other biomarkers or potential targets that are upcoming. Many of these are currently in phase 1 or early phase clinical trials. So those are definitely the considerations before we put patients on the standard of care ramucirumab paclitaxel.
I agree. You know, it's kind of funny that there's a lot of agents that are encouraging, but nobody has beaten Taxol and Ram head-to-head yet. We'll see if this ever happens. I know that it's an active combination, and we'll just have to wait and see if anyone goes head-to-head and actually winds up winning. Tell us a little bit about, you've done some ADC work. ADCs are everywhere in all types of solid tumors that just seem to be hot right now. You mentioned HER2 positive disease, so maybe tell us a little bit about your standard for frontline HER2 positive patients and then trial approaches that you're interested in.
So standard HER2 positives, I think we now have the Keynote 811 as our standard option. So depending on whether they have high PD-L1 expression or not, the FOLFOX plus trastuzumab with or without pembrolizumab is now our standard. We do have an interesting first-line clinical trial option in that setting, trying to evaluate the trastuzumab deruxtecan, that antibody-drug conjugate, in different settings with different combinations. So I can talk to you more about that trial that we have available at our institution.
Yeah, I think it'd be interesting just to hear the combinations that are being explored, because I think they reflect things that are happening beyond HER2 as well.
Yes. So this trial is called Destiny Gastric 03, and it is a phase 1 study, but they're evaluating multiple different cohorts with trastuzumab deruxtecan. And some of the combinations include chemotherapy combinations, pembrolizumab, and there's some novel immunotherapy, the bispecific agents targeting the CTLA-4 PD-1 combo, and there's a TIGIT PD-1 combo as well. And they're trying to bring the trastuzumab deruxtecan into the first-line setting, both for HER2 overexpressing and the HER2 low expressing, so IHC 1 plus and 2 plus with FISH negative gastric and esophageal adenocarcinomas.
Yeah, that would be quite interesting if we can model our approaches a little bit after the breast cancer colleagues who are a little bit ahead of us maybe in testing the HER2 low population. I peripherally follow along that data, and it does look encouraging that maybe the same will hold for gastric cancer. We'll see. This is a common question that I think we all get with the anticipated upcoming approval of zolbetuximab. We're going to have these patients who are HER2 positive and Claudin positive, and HER2 positive and Claudin negative, and PD-L1 negative and Claudin positive, and sort of every combination you can think of. Where do you think the sweet spot for Claudin is going to fit? Is it this Claudin positive PD-L1 negative patient? Is it the Claudin positive PD-L1 low? How are you thinking about this in anticipation of the future availability? I know it's available in Japan, but we're not in Japan.
I agree. I think we're almost there. I think this is where your analogy with the breast cancer also applies. They've, categorized this ER positive, PR positive, HER2 positive, triple negative, all these different subsets. And I feel like we're headed that way too. And specifically for the Claudin 18.2s, I agree with you. I think that sweet spot is, with the data that we have, it'll be the Claudin positive, HER2 negative, and PD-L1 low expressing or negative group. That's probably where the first indication would be. And with all these new biomarkers, I think figuring out which ones are more important than the others and how we should prioritize these, that would be our big hallmark over the next couple of years.
Yeah, I totally agree. Hitting even like quadruplets up front versus sequencing strategies versus what happens to these biomarkers over time. I mean, these are all big questions for people like you and others to try to answer. Maybe to start the conversation, let's say zolbetuximab is available and you give Folfox plus Zolbe per a spotlight trial and the patient progresses and you have a Claudin ADC available in the second line on a trial. Are you thinking that you're going to like rebiopsy these patients like we do for HER2 and retest Claudin? I mean, this is a little bit of a future looking question.
Yeah, that's exactly what I would do. Without really a whole lot of data supporting that decision, we'll do similar to what we do with HER2s in the Claudin positive population. And it's interesting. There are a lot of different Claudin targeting approaches these days. I actually Googled it, and there are maybe 50, 60 clinical trials with different Claudin-82 targeting drugs. So these antibody drug conjugates, cellular therapies, bispecifics, there are a lot of different options out there. So I would definitely give it a try if the patient still had Claudin-82 expression.
I think exactly the same for me. I mean, all these agents, you're right. The T-cell engagers, the ADCs, the antibodies like zolbetuximab, all of them have shown activity. Of course, Zolbe is the farthest along with phase 3 data, but we'll see a lot of trials to come. In the last minute or two, I want to ask another question that comes up a lot, and we saw a little bit of data at ASCO from this Renaissance trial. But the same patient example I gave you who recurred with one liver met and a couple retroperitoneal lymph nodes. A lot of our patients come in and ask, what about just removing this? And surgery for stage 4 and topics along those lines have been a question for a long time. Renaissance looked like surgery does not improve survival when it's scheduled into management of stage 4. Do you guys think about surgery for these patients, or you feel like it's a systemic disease, we need systemic therapy?
Overall, I think it is systemic disease, and we probably have to improve upon our systemic therapy options. But having said that, I think I'll have those, one or two patients who's had very indolent disease who probably could have benefited from surgical approach. And I actually do have a patient who's had surgical resection of oligometastatic liver lesion and who had done very well. So I think it's a matter of selecting the right patient population who can potentially benefit from those local therapies for those oligometastatic diseases.
I agree. I think they're out there. In the Renaissance, they only got 2 months of plot before being randomized to surgery or continuation. When you do this for your own patients, I know that it's individualized, but ballpark, how long of systemic therapy do you think we need before we can pick those patients out a little bit better?
Personally, I would probably do at least 2 restaging scans showing that the disease is stable, that we've gotten maximum benefit from the chemotherapy.
I'm with you. I'm like a 3 to 6 months kind of window.
Yep.
Yeah. I think that it feels better like you've done that biologic time we talk about. I completely agree. Well, look, it's been great having you. We're winding down on time, so thanks for tuning in. We talked a little bit about Esopec, increasing FLOT, and perhaps replacing chemoradiation for esophageal adenocarcinoma. Talked about frontline management and how to incorporate PD-L1 testing. We talked about new targets like Claudin 18.2 and future things that Dr. Park is interested in. So please take a moment to download the Medscape app to listen, subscribe to this podcast series on esophageal cancer, and this is Sam Klempner for the Medscape In Discussion Esophageal Cancer podcast, and thank you again.
Thanks for listening to Medscape's In Discussion Esophageal Cancer podcast series with our host, Dr. Samuel J. Klempner. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on esophageal cancer.